mind. If you have a suspicion of voiding pathology for which you have asked for urodynamics, you will expect a voiding. In the voiding phase, you will expect some abnormality. If this patient comes to you with a poor flow in whom you suspect atrophic vaginitis causing distal urethral stenosis, then you should be able to correlate the urodynamics findings with the clinical picture that you have in mind. If in case the picture that you have in mind does not correlate with the report that you have in hand, repeat the urodynamics. Never ever hesitate to repeat the urodynamics. You don't have to repeat the entire urodynamics. You can just ask for repeat voiding phase alone or the repeat filling phase alone. If suppose the patient has got overactive bladder, in which case during filling phase the overactivity of the bladder is not demonstrable, you may have to repeat only the filling phase here to see if there are any uninhibited reserve contractions. If you suspect a female BOO, then in which case you can just fill the bladder a bit and then give rest to the bladder for 2-3 minutes, and then you can record the voiding, where you can save time when you repeat the urodynamics. Don't have to necessarily fill the bladder again at 5 or 10 and you spend about 20 minutes on filling the bladder alone. Don't have to do that. And until you get the diagnosis in hand with the urodynamics, the diagnosis is actually not certain. Thank you.
What I take home is I like to ask 2 questions on the post we have understood. Can I ask? You explained it so well. In the filling phase, suppose there is hyperactivity more than 15. What is the diagnosis? The filling phase of urodynamic, filling phase, there is hyperactivity of more than 15 centimeters. Senior physician should answer it. No point of the Sriram and talking for elaborate presentation. I want senior physician to understand the subject and filling phase in a UDS. What does it mean? Some hypercontraction. Spikes are there. What does it mean? Feed it. I'm not only feed it. I'll talk only about feed it. Feed it, nothing but P cycle minus P of down. What is coming? It shows why indirectly the diagnosis for overactivity. Suppose you have a genuine stress incontinence. What is the UDL show? Filling phase and voiding phase. I'm talking about genuine stress incontinence. This is very correctly. In mixed incontinence, hyperreflexia, the genuine stress incontinence, UDS, filling phase, voiding phase will be normal here. You diagnose stress not by UDS. I'm talking about genuine stress incontinence. I correctly say the mixed incontinence is different. Suppose a patient stress incontinence and in between he has urge to void. Then you do UDS, then you will find a spike. The treatment varies. But in genuine, word is very clear. Genuine stress incontinence. What's the UDS diagnosis? It is normal. You diagnose stress incontinence by doing urethral pressure profile. That is nowadays, I don't know how it is. In the case of genuine stress incontinence, UDS, filling phase will be normal, providing phase will be normal. Other PG, senior PG, he is taking a fantastic take-home message, and he said very clear, very important point. You should read the UDS by yourself with the clinical presentation. And voiding chart, most important. Most of urologists, I don't see. You have to have voiding chart. How much ml passes urine, how many, what hour gap, everything. Fantastic. So you've given a fantastic message. Am I correct or not? UD should be read by the person present, and genuine stress incontinence will be a normal UDS presentation. Another thing I want to ask, just for sake of it, what is the role of ambulatory urodynamics in case of urgency frequency or active? Just few words for sake of. See, in a case of overactive bladder, we don't know when the it is called something called trigger points. When lifting a bucket, if you have a spikes, urgency spike. So what they do, they have a monitor in the abdomen. They put a transducer, which is a sensory transducer, and 24 hours they have around the abdomen, and they read the thing, and they find out what triggers the overactive bladder. Triggering point. It can be lifting things on top, or lifting a bucket, or going to anywhere, driving a car. It is overactive bladder, ambulatory urodynamics. How far useful? I think our subsequent result. In genuine stress incontinence, what is UDS will be normal. You are diagnosed only by urethral pressure profile. Nowadays, I don't know they're doing What's your we talk subsequently? Fantastic, you take it. Very nice and natural. Take home message.
Sriram, you have a wonderful conclusion. That is, we must have clinical diagnosis first. Then only the urodynamic findings correlate with that. If it is not correlating, then it will have only less important. Because obstructed men and leaking women are the two major challenges in the urological practice. Whenever we do this urodynamic study, it's a wonderful study, but you must always correlate with the clinical patient view. So when you do the study, there are 3 points. That is, in the building phase, at 150 to 250 ml, the patient will perceive the first sensation of passing urine. That's the first sensation. Okay. Second is, at 250 to 350, this is the range. This is 250, the patient will have the urgency. This is the second point. The third point is, what we did the last 450 and above, the patient will be compelled to pass urine. That irresistible urgency. These 3 points you must always remember, and each has got, it is represented by 3 systems and 3 circuits. The first one, that is this 150 sensation, is carried out by the sympathetics. With hypogastric to the T10 to T12 and to higher centers. This is just a sensation only. The second is 350, that is 250, 350. The patient with urgency. Here it is caused by the parasympathetic, that is the decussar contraction. This is the second point. The patient, the decussar will contract, this is the parasympathetic. The patient will have, this is a very common problem in most of the cases of OAV. Patient will have urgency. At this stage, the patient will be given the backup mechanism. The backup mechanism will come into O. That is, the sphincter and the pelvic diaphragm will contract and prevent, try to hold the urine from contract till the individual finds a normal, convenient place. You have, because everybody will be in the work or walking around. So, till the time, this hold-up mechanism will help. The last point, so the individual has to decide, okay, now it will empty himself or will postpone for some time. That will be another handle number 450 ml. The patient will have the severe urgency, and at this stage, this is controlled by the external sphincter and the pulmonary nerve here. That is voluntary. The patient will voluntarily contract the sphincter and pelvic muscles, and also the gluteal muscles also. So, first is sympathetic, second is parasympathetic, last comes the pulmonary nerve. All the 3 systems are involved. This is the system. Then there are 3 circuits. So, 3 circuits, there is the frontal circuit, mid-cingulate circuit, and the gangliomotor circuit. The frontal circuit, which controls the first one, that the patient perceives the pain. The second one is the mid-cingulate, which controls, which is the backup mechanism. The last one is called the gangliomotor. That is the one which controls the pulmonary nerve and causes the patient to contract the external sphincter. So when you see a urodynamic showing the system for every patient it will be variable, because it is not one particular value, 150 or that will always give a range. So you must find out at what point the patient perceives, when the urgency comes, and the last one. So based on that, you will be able to choose that exactly the problem of the patient according to the medicine tailor. Right, we have a very good coverage of the whole topic today. Another.
Very good presentation, Sriram.
Thank you very much, Sriram, for the wonderful presentation. Madam's comments we have reserved because Madam has got a lot long way to go. She's a last topic is Madam's topic. She'll be here for both our sessions. Thank you, Madam. I request Professor Shivashankar sir to kindly hand over a small memento to Sriram. Yes, sir.
As usual, Sriram has an excellent job. Very short, but conveyed the whole message. I think the postgraduate students would have benefited by this small talk, but very important points he has pointed out. Please be mindful with that. Thank you. Thank you, Shriram.
May request the chairpersons to kindly join for the photograph, please. I request our director sir also to give a small moment of appreciation to our chairpersons, please. Professor Mutulata ma'am, Professor Vairaved sir, and Professor Rajaram sir. Thank you very much. Thank you very much, Shriram, for the wonderful talk. You kept on time and the session gets going. Thank you very much. I know you have a commitment and you will have to leave. Thank you for being with us. The other big problem which we face when it comes to urogynecology is you often see in your practice a woman comes to you and says, I got a urinary tract infection. And after some time, she comes back within 2 weeks and says, once again, I got an UTI. You treat the patient. The patient goes back and comes to you in a month's time and says, I got an UTI. The next question she asks is, sir, why am I having this problem again and again? That is where you have to understand the physiology of the women is a little different from the physiology of men when it comes to urinary tract infection. And we have Dr. Meera Raghavan here to kindly discuss on how different a urinary tract infection is from a man and a woman and how to understand the physiology and go ahead with the treatment. May I request Professor Shrikala ma'am to kindly be on the chair, please. May I request Professor Edith Sundar to kindly be on the chair. And may I request Dr. M.G. Shekhar to kindly be on the chair, please.
Good morning to everybody. It's a nice pleasure to see Meera, my close friend, talking on this wonderful topic. She is not only a wonderful surgeon, her talks are always lovely. So Meera, the floor is open to you. Thank you, madam.
Good morning, everyone. Hope I'm audible. Many thanks for this lovely opportunity to be in my alma mater where I began my undergraduate studies, and I'm coming back after I went for post-graduation only today, and it feels greatly nostalgic to be back. And thanks for this wonderful opportunity. UTI in women definitely much different from men. Presence with recurrence, persistence, as well as when they get complicated can be serious. Usually men have an underlying pathology why they would develop a UTI and which can become recurrent. However, in women, physiological changes attributable to women's journey through her life of a reproductive span itself can predispose women to a higher risk of urinary tract infection, a higher preponderance to recurrence and complications. So we're going to see why this happens frequently in women. Just a bit of history around interesting tidbits about UTI. It was way long back in 1550 BC, which reported the possible symptoms of UTI. And it is the second most common infectious presentation in community practices. In fact, I tell my women, especially above 65, the two things which you should have an aggressive approach or immediate attention to is chest infection and urinary tract infection. Otherwise, you can end up even losing the patient if there is a delay in institution of treatment. So worldwide, about 150 million people are diagnosed with UTI each year. It shows the magnitude of the problem which we all face. It's actually an inflammatory response of the urothelium, which lines the bladder in response to the bacterial invasion. So we need to really pick our battles to fight and not keep every culture report, only the symptoms. UTI occurs in females and males irrespective of the age group. However, age increases, the preponderance to UTI recurrence also increases. And antibiotics have made a huge advancement in the management of UTI. However, it itself has become a double-edged sword, and we are running out of antibiotic choices now because of multi-drug resistant bacteria, because probably the bugs have become super smart than the doctors and the antibiotics available themselves. So approximately 50% of women, so if I take a room of 100, despite antibiotic treatment, a third of them experience a second episode within 3 to 4 months of the initial infection. And globally, we have understood how the magnitude of the problem can be. And if you equate it to daily disability adjusted life years, it contributed to about 5.2 million disability adjusted life years. So it definitely affects the quality of life as well. As I said, a predisposition because of an anatomical or a functional abnormality of the tract will increase chances of physiological changes during the reproductive span, predisposes especially elderly women to a higher risk of UTI as compared to their male counterparts. Similarly, in younger girls, 8% of girls can experience UTI as opposed to 2% of the boys, when the 2% in the boys will have some anatomical or functional abnormality related to the urinary tract. So most UTI occur in women who are healthy, and interaction between the bacterial virulence and the host defense mechanism is what determines how severe or complicated the UTI can get. So whenever the bacteria are virulent or there is a depletion in the host defense mechanism, the preponderance to infection happens, the exacerbation of colonization happens, and the expression with which the severity of the infection also is determined by this balance. So we all know there could be a genetic predisposition and a familial tendency for the uroepithelial susceptibility to these infections, which is further exacerbated by the vaginal mucous properties. And these are the host factors which are very important in the causation of UTI in women. Apart from that, if they have behavioral dysfunctional voiding, I'm not going to call it voiding dysfunction. When they have a dysfunctional voiding, we all know that women do not need an active detrusor contraction to void. It is a passive phenomenon by pelvic floor relaxation. If the pelvic floor does not relax and it's tonically contracted, they potentially can develop a post-voidal residual urine volume, and that itself can predispose to recurrent urinary tract infection. So many of these women who have had sexual abuse, trauma, or some kind of previous surgery, who have had pelvic floor tonic spasms, can end up in dysfunctional voiding and strain with Valsalva to void, which itself further worsens the dysfunctional voiding. Apart from that, frequent sexual intercourses, multiple sexual partners, though UTI is not a sexually transmitted disease. UTI can occur because of the alteration in the vaginal pH, because of the use of certain types of condoms, spermicide, as well as the semen pH, which makes it alkaline, predisposes the woman counterpart to have recurrent UTI rather than taking it as a UTI being a sexually transmitted disease. And this is because of the periurethral colonization of the host bacteria, which is the E. coli. There's usually three main bacteria which we always counter when we treat women. It's E. coli, followed by Enterococcus and Klebsiella, which are usually fecal contamination, which colonize the vaginal epithelium as well as the urethral epithelium. So again, the reason why the greater susceptibility of the women to UTI is because of the shorter female urethra and the proximity to the anal canal, and therefore contamination or colonization. So it's the female anatomy, sexual activity, certain types of contraceptives, and menopause, which can predispose women during their life journey themselves to recurrent UTI. And other risk factors which increase our urinary tract abnormalities, any blockage in the form of renal calculi, just like men, a suppressed immune system. And what we see commonly is diabetes and Certain autoimmune disorders as well, when they are having SLE and Sjogren's syndrome, they are associated with vaginal mucosa, which is dry, as well as stenosis of the urethra, which further predisposes them to recurrent UTI. Of course, catheter-associated UTI, any recent urinary procedure or urinary surgery, neurogenic bladder and spinal cord injury, and not to forget pregnancy and post-breastfeeding patients postpartum. So UTI, like men, it is complicated and uncomplicated. When there is a normal host, you call it uncomplicated. When there is a compromise or there is an alteration in the defense mechanism and other risk factors, we call it complicated. So in women, when there is a pregnancy associated, catheter associated, when the host is diabetic or immunocompromised, when there is an anatomical presence of stones which causes obstruction in an elderly woman, they are or complicated UTI. And uncomplicated is what we commonly see in the community. And clinical presentation of uncomplicated UTI, we have to differentiate between an asymptomatic bacteria and a cystitis. Cystitis is just bladder presence of infection. If it further ascends, it's going to become a pyelonephritis. If the patient is not at all symptomatic, and we pick it on culture and the colony count still comes as less than 1 lakh, we should really refrain from treating these women as this is an asymptomatic bacteria. The more we treat them, the more we are going to propagate the presence of multi-drug resistant bacteria and the more challenges with regards to what antibiotic we're going to choose. This is about antibiotic stewardship, which we all should practice as clinicians. So I'm just giving an elaborate form of the complicated UTI. I'm going to home in only on the pregnancy and the diabetes. UTI in about 8% of pregnant women, they can be asymptomatic. Asymptomatic bacteriuria in pregnancy is the main indication where you will treat asymptomatic bacteriuria. The reason being, this itself can predispose to preterm labor, iron deficiency anemia, low birth weight in the baby, and intrauterine growth retardation, apart from becoming a complicated UTI. So the only indication for treating an asymptomatic bacteria in women is pregnancy related, and they have to be treated, and a test for cure should always be repeated subsequently after 2 weeks to make sure you do not find any colonies of bacteria. Otherwise, it can have perinatal impact in the outcome of the babies. So uncomplicated UTI, we all know the main symptoms: dysuria, frequency, urgency, hematuria, and suprapubic pain. When it gets complicated or ascends up, you can get flank pain, fever, chills, as well as abdominal pain. So just to give you a kind of differential relationship between UTI in men and women, the anatomy and the distance and proximity to the anal canal determines the higher preponderance of women UTI because of the shorter urethra, frequent infections and multiple infections each year in women, and E. coli and Enterococcus are the main bacteria which we usually find. And it is always related to staying hydrated, seeking timely medical attention, and proper hygiene. When I mention proper hygiene, we have to actively discourage overt hygiene. Women have this obsession that using public toilets or practicing excess perineal hygiene will prevent them from having recurrent UTI. And they continuously use vaginal douches, antiseptic solutions, or commercially available vaginal washes. We as practitioners have to actively discourage the use of commercially available washes because these can kind of denude the friendly bacteria from the vaginal epithelium and predispose them to recurrent urinary tract infection. So not only advocating proper perineal hygiene, but actively discouraging excess perineal hygiene is one of the mandatory advices we need to give as health practitioners to our women to prevent recurrent urinary tract infection. I would like to also touch upon the other issues which can mimic symptoms of UTI, especially bacterial vaginosis. presence with vaginal itching, as well as burning during urination, as well as a fishy odor, vaginal discharge. This again is not associated with sexual transmission, but can be present with other sexually transmitted infection as well. It is a definite risk during pregnancy and breastfeeding and can cause pelvic inflammatory disease. So importantly, they have to quit smoking, avoid excess vaginal washing, vaginal douching, and avoid a multiple number of partners. Prolapse in women also predisposes women to recurrent urinary tract infection because it impairs the bladder emptying, allowing for stagnation of urine and therefore excessive bacterial growth. So vaginal prolapse lip pair or apical suspension is important to restore the pelvic anatomy, the vaginal axis, and thereby allowing the bladder to empty properly. So it is important to determine the root cause of the UTI in a patient with pelvic organ prolapse and not just treat the UTI alone. And this is one of the reasons called to examine these patients' predisposing factor for recurrent UTI in the females. Do fibroids contribute to recurrent UTI? Yes, by bladder pressure. And if they're going to be present in the lower segment, they will kink the urethra and thereby impair the bladder emptying. Again, the symptoms can overlap because of pelvic pain, pressure in the pelvic area, frequent urination, discomfort in the lower abdomen. And when you're already thinking only about fibroids, you might miss the UTI and take it for granted it would be just fibroid-related symptoms. Very, very common. We put it under menopause, where you have symptoms, vaginal and irritation, apart from lower urinary tract symptoms like frequent urination, dysuria, or irritation and constant urge to pee. And the third arm of the triad being sexual dysfunction. So it is persistently ask, not taken for granted like what the undergrads ask discreetly. So please do ask uremia and any abstinence from sex because of the irritative symptoms. So it's painful intercourse and increase in urinary tract infection. The commonest reason is reduction in the level of estrogen, which is about after menopause, especially surgical menopause and anti-estrogen drugs. So very common in patients who receive chemotherapy and hormone therapy with tamoxifen after breast cancer. Radiation cystitis, again, the most important feature being hematuria, and they can have voiding dysfunction and painful bladder as well. They are predisposed to recurrent urinary tract infection because of the ischemia and the fibrosis which happen inside the bladder. This tends to happen years after the initial radiation, especially what we see in CA cervix patient, and they have to be treated appropriately. The other issue which can mimic recurrent